Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
When it comes to seeing a variety of patients, nowhere in medicine is the patient population more diverse than in the emergency department. Emergency medicine physicians treat everyone, from babies to the elderly, from trauma patients to those who are worried about a cough or a sore throat or a fever.
In the ever-changing world of medicine, emergency departments are looking for ways to improve their practices and treat patients efficiently and effectively. One improvement Mayo Clinic is making is launching an emergency department telemedicine program. Here to discuss is the Director of Community Emergency Medicine at Mayo Clinic, Dr. Christopher Russi. Welcome to the program, Dr. Russi. We're happy to have you here.
Thanks for having me.
Dr. Russi, good to have you. I'm going to ask you first the question that everybody out there wants to ask, and that is, why do I have to wait so long in the emergency room? Sometimes. Not always, sometimes.
Are you bleeding out of your eyes?
Well, then I think I'd
yeah,
get right
you
in.
would. That's right.
That is a very difficult question to answer, and we know that we share that pain. We want to be efficient. We want to meet people's needs expeditiously, but the emergency medicine, our volumes go up every single year, and people are sicker in this country. They have more issues.
More complex problems.
More complex problems, a lack of primary care in some cases. And so that all leads to emergency medicine volumes climbing.
Are you seeing a lot of things that actually should be seen in an urgent care center? Don't you deal with a lot of relatively mundane things that aren't true emergencies? And how do we solve that problem?
I wouldn't say that in the most part. I mean, there are times, yes, of course, when we see some things that maybe don't need the emergency department. However, patients are worried. Patients have fears. Patients have concerns. And that's why we're there. We're there to waylay those concerns, make sure there's nothing serious or urgent at that time. And we're happy to do that. I think the myth exists that we're seeing nothing but urgent care stuff, and that's functionally not true. Especially here on our campus in Rochester, we have high acuity patients and high volume of them.
Well, and I think part of the problem is that there's a lot of people in the waiting room. And all of a sudden you get a 4-car accident with a bunch of trauma victims, or you get somebody with a heart attack, or 3 people with a heart attack, and obviously you have to go take care of those people first, and that means that the people in the waiting room have to wait who don't have quite as serious an injury or not quite as acute.
That's right. That's absolutely right.
Tough problem.
It is, and communicating with those patients that, look, I'm really sorry for the delays. We've had some serious things happen, and the communication process and updating those patients is critically important, which we try our best to do.
Is there a typical day in the emergency department?
No.
Is it exciting to work there some days, and some days not so much?
Well, it's interesting you ask that question. Emergency medicine is the #1 burnout specialty in the House of Medicine.
Really?
Consistently. There's a myriad of reasons for that, but our specialty is the top burnout specialty.
No. I thought that because you had limited hours, specific hours, and when you went home, somebody else took over, that it would probably be less stressful.
That's one of the beauties of our job is when I go home, I'm not on call.
Right.
It's shift-based, but it's also very difficult to do shift-based work. We handle a serious flood of patients, a serious volume of patients in a short window. The regulatory environment around the medical record and what we have to document is profound.
The paperwork is a killer.
To do that volume in that amount of time with that paperwork. And shift work is hard on your physiology. To do nights, to do evenings. It's hard to be 24/7, 365, and on Christmas, on New Year's, on your birthday. So there is a downside to it. Is it fun? Absolutely. I mean, I've been doing it now, 18 years since I started residency. But there are days. There are very difficult days.
In those 18 years for you or for the other folks that you work with, how has the opioid crisis affected what you do each day?
This is a sad national tragedy. And so it's affecting us on multiple fronts. Namely, there's a large body of research that's coming out on how we can provide alternative ways to help with pain in the emergency department. We're trying to adhere to those or look at those very closely. Partnering with our friends in family medicine, in internal medicine, our friends in anesthesia that run the pain clinic. adhering to their guidelines, and minimizing the amount of opiates that we actually give to patients on an outpatient basis.
So where are all these pills coming from? I don't quite understand it. Is it truly because we have overprescribed narcotics, or are some of these pills coming in from foreign places, overseas, being brought into the country?
I haven't heard that. There's some excellent documentaries out there, and I'm not sure I'm in a position to say where they're coming from. I don't know. But we, as the safety net and the hub of healthcare in the emergency department, have a unique opportunity to help shape the conversation and to help our patients minimize the use, and through a collaborative effort with our friends on the outpatient side to make sure we're doing the right thing.
As you have learned better, you have done better when it comes to opioids?
I think so.
Yeah.
We have some talented people in our department. I'll mention one. Dr. Casey Clements is working very hard on this, and we're very thankful for his work. And so we're seeing in our own practice an evolution. I think it's going to evolve more, and you're seeing it on a national level.
So you are the director of community emergency medicine. So how many emergency rooms do you oversee? How many emergency rooms does Mayo run in the upper Midwest?
Sure. So I serve as the division chair for our department, and we have 21 total departments. Wow. One of those is our academic hub here in Rochester. The remaining 20 are a variety of trauma centers and critical access hospitals. 10 of those 20 are critical access, hold a federal designation of critical access hospital.
And what does that mean, critical access?
There's a lengthy definition on CMS, but it means essentially you're in a rural environment, you're at a significant distance away from another site. And
you can take care of serious injuries.
You have to. They have to have an emergency department 24/7, 365, be a remote distance away from another site, and serve a rural populace, essentially.
What changes is Mayo Clinic making to their emergency department?
So the biggest one that we've made in our Midwest practice is the evolution of our nurse practitioner and physician assistant workforce, the NPPA workforce. They are primarily staffing those critical access sites now. We have low volume, but sometimes they have high acuity.
What does that mean?
So they don't see a lot of patients on an annual schedule, but the patients that do come are fairly sick, just like they are everywhere. Nurse practitioners and physician assistants, interestingly, in their training, get little to no exposure to emergency medicine. And as the number one burnout specialty, you take someone who isn't even exposed to what we do, plump them into our environment, it's ripe for burnout. And so because of that, we've developed a fellowship training program for those individuals. And as we wanted to talk about our telemedicine program to support them as well.
Well, that's right. Let's talk about telemedicine. Tell us about that program.
This is really exciting. We've been working on this for several years. In healthcare, as you are probably well aware, there's a big shift into the digital world. I think we're a few years away from you actually interacting with your provider through a digital medium, either asynchronous or asynchronous means. We want to support, the impetus for our program was to support our nurse practitioner and physician assistant workforce. So when they're out in St. James or Waseca or Osseo, Wisconsin, and they have someone really sick and they need some advice, they need some guidance, we're there.
They can Skype you.
Yeah, so the Center for Connected Care has contracted with a company. We have a technology system in place, and we can just talk through a video system, which it's really nice. Moving forward, we'd like to see this potentially expand to our regional partners, or our regional competitors, if you will. A lot of non-Mayo facilities send patients into Rochester and to our regional hubs. I think we can support them as well, and then further expanding potentially to the Mayo Clinic Care Network.
And maybe they wouldn't have to come. You could take care of it via video.
That's, ideally keeping patients local is wonderful. It's good for the patient. It's good for the family. Yes.
All right. We've been talking about advances in emergency medicine and tele-emergency medicine with the Director of Community Emergency Medicine, at Mayo Clinic, Dr. Christopher Russi. Thanks for joining us, Dr. Russi.
Thanks for having me.